Assalamu alaikum. Hello everyone. This is Dr. Hesham Wageh. This is our third session. Today we are going a most important topic, which is trauma. Trauma is an important topic for paper 2 MRCS. Before I start, some of you asked for an advice regarding the next exams about September 2020 and January 2021. I'm going to tell you something. Whatever the exam time, you should know that you must pass. Nothing will be left for you except you should do it, okay? From the start, please focus. If you start from today, from now, for September exam 2020, you will do it. You have more than 2 months. I know people, and they are my friends, who passed within 1.5 months. They are not more intelligent than you. They are not more better than you. You can do it. So please focus on your goal. Please stay strong. You will do it. All of us has the same power. Don't worry for that. You will do it. You will pass. Please focus. Please study hard. Even you start from now, please. All I want from you is just to follow our free sessions. And I will add some notes in the Telegram group. Okay? If anyone has any question regarding the next exams, after our session today, I am free. I will answer any question regarding that. Okay, but please not to waste more time. I'm going to start the session for today. This is our third session for paper 2 from online past test 2020. Our topic today is trauma. Okay, now I'm going to clarify some questions regarding the trauma. As I told before, any patient with burn or trauma is managed in the UK protocol according to advanced trauma life support. Otherwise, any critically ill surgical patient is managed according to CRISP protocol, care of critically ill surgical patients. So when I'm going to discuss trauma, so I will discuss advanced trauma life support algorithm. Okay. Then now I will share photo from our notes regarding advanced trauma life support algorithm, which is an EPCDE. E, assessment of the airway and the maintain patency of the airway plus cervical spine protection and immobilization. And this is an important point. This is an important point, okay? Cervical spine, not to be missed. Please do not forget the cervical spine immobilization. So when assessment of the airway, I am going to look for, initially, if there is any foreign body in the mouth which can obscure the airway. So I am going to remove this foreign body first. Then assess if the patient airway is improved or not. I'm going to assess the patient by, which is the look, listen, feel. A look for any foreign bodies, then listen for any abnormal sounds like gurgling, grunting, stridor. Then feel the air which go in and out in the mouth of the patient on your cheek. Okay, look, listen, and feel. Then you will remove the foreign body, then assess the airway. How to maintain patency of the airway? Initially, after removal of the foreign body, I will do chin lift and jaw thrust. Okay, chin lift and jaw thrust. In some books, jaw thrust is only preferred because a chin lift, if the patient has cervical spine injury, you may exaggerate that. Okay, then you can do jaw thrust only. After chin lift or jaw thrust, if the patient is not taking his breath no air going in and out from his mouth, no chest wall movement. What will you do? You will do oropharyngeal or orotracheal airway. Okay, this is the oropharyngeal airway or nasopharyngeal airway, a small airway, girdle airway, where you can put it to maintain the airway patent. If not, and you cannot maintain the airway patent with the oropharyngeal or nasopharyngeal airway, then you will go for mechanical ventilation and endotracheal intubation. Okay, endotracheal intubation. And here are another surgical options, but they are after endotracheal intubation option. Surgical options like needle cricothyroidotomy or surgical cricothyroidotomy, where you do an incision through the cricothyroid membrane between the thyroid cartilage and the cricoid cartilage. And the last one is tracheostomy. When will you do the surgical airway? Failed intubation or patient with fracture larynx. Okay, then assessment of the airway. The second is the breathing and ventilation. You will look for the chest of the patient. If there is any injuries of like tension pneumothorax, and tension pneumothorax is an important topic here in trauma. We will discuss it by every detail because tension pneumothorax is commonly asked question in the MRCS. And also you look for flail segments of the chest, which move up and down with the respiration. Also, if there is any penetrating injury through the chest and causing hemothorax. Circulation. What's the most important in management of the circulation? The first thing to be done is control of hemorrhage by pressure and packing, not by using a tourniquet. If you have a bleeding from a point, even at your arm, for example, then you will do pressure and packing, not a tourniquet over the arm. Tourniquet is not allowed to be done. This is the hemorrhage control. Then disability and neurological assessment of the patient according to Glasgow Coma Scale and EVPU system, alert, verbal pain, unresponsive. Lastly, exposure to look for any spinal injuries, like if there is any bruises, any tenderness of the patient. We have the log roll system where we can use 4 persons to log roll the patient. Simply, assessment of the advanced trauma life support will be airway, breathing, circulation, disability, and exposure. Okay, let's talk specifically about every trauma. Fracture larynx, fracture larynx. And you can see some sort, it is strange for you to know this. Please focus. Larynx is formed of cricoid cartilage, arytenoid cartilage. Okay, here is the cricoid cartilage. We have a fracture here. Okay, this is a fracture of the cricoid cartilage. Cricoid cartilage is the level of C6, hyoid, HTC. Hyoid is the level of C3. Thyroid is the level of C4 and 5. Then cricoid is the level of C6. And there are multiple events which occur at the level of the C6. I will tell you later about that, okay? Then how to classify laryngeal fracture. There is a classification of fracture of larynx. Here you are. It is called Sheffer classification of laryngeal trauma and management. Management, there is an algorithm of laryngeal trauma, but groups, 4 groups for Sheffer classification of laryngeal trauma. The most important for us is group 3 and 4. But initially, you will know that there are 5 groups. I will classify them 1 group alone, then the 3 groups with each other. The first group, where there is minor airway symptoms, but from group 2 to group 4, there is major airway compromise. All of them will be presented by hematoma, edema, and prominent cartilage, hematoma, edema, and the prominent cartilage. And the management will be done according to the next algorithm. So laryngeal fracture, it is not common. It is not common to see laryngeal fracture because the neck usually is protected from above by the mandible and from the lower part from the chest. So it is difficult for you to see some laryngeal fracture, but it occurs. So to know the laryngeal fracture, there is fracture of the thyroid cartilage or arytenoid cartilage or cricoid cartilage, and they can be classified according to Sheffer classification. 4 groups. Group 1 with minor airway symptoms, but from group 2 to group 4, there is major airway compromise. The patient will present by hematoma, edema, and exposed cartilage. In 3 and 4, which I told you, there is a vocal cord immobility. This is important. Management will be according to the next algorithm. Okay, I send you the next algorithm. Okay, you can focus on that. This is an important approach for management of the neck trauma at all. Neck trauma at all, not specific for laryngeal fracture only. When the patient is traumatized to the neck, neck trauma is classified into 3 zones. The 3 zones of the neck trauma I sent yesterday evening at the Telegram channel, which is the zone 1 of the neck trauma from the thoracic inlet till the level of the cricoid cartilage. Zone 2 from the cricoid cartilage till the level of the mandible. And zone 3 is above the mandible. The most important investigation to be done for any trauma at the neck, even zone 1 or zone 2, zone 3, is the CT angio. CTA, CTA, CTA. This is also important. In zone 1, which is found from the level of the thoracic inlet to the cricoid cartilage, our management will be endovascular immobilization. Okay, endovascular embolization. Okay, then from zone 1, zone 2, zone 3, the most important investigation, which is commonly asked in neck trauma, is CT angio. Okay, I will clarify to you some pictures for neck trauma zones. Like this. This is zone 1 from the thoracic inlet to the level of the cricoid cartilage at the level of the C6. From C6 to the mandible, this is the zone 2. Zone 3 is above the mandible, and it can include maxillofacial trauma. Okay, another one. Okay, like that. This is also zones of neck from thoracic inlet to the cricoid cartilage, from cricoid cartilage to the angle of the mandible, then above the angle of the mandible. Okay, then I am going to clarify some questions about cardiac tamponade. How cardiac tamponade occurs? Cardiac tamponade can occur due to direct trauma causing tamponading of the heart by the accumulation of the blood within the pericardium. Okay, then after that, the patient is diagnosed by what's called PICS triad. PICS triad is increased jugular venous pressure and hypotension and the muffled heart sound. This triad is very important and the most commonly question asked in the MRCS. Triad of cardiac tamponade is called PICS triad. Increased jugular venous pressure, hypotension, and the muffled heart sound. Also, there are 2 signs which can be asked: cosmal sign and pulsus alternans. Cosmal sign, where there is raised jugular venous pressure on inspiration; pulsus alternans, strong wave, then weak wave. So there are 3 important information regarding cardiac tamponade: PICS triad, cosmal sign, pulsus alternans. Okay. On X-rays, the cardiac tamponade is appeared like globular heart. Globular heart. This is also a question asked. Okay, cardiac tamponade. Also, regarding the chest, diagnosis of hemothorax. Massive hemothorax, which occurred due to rupture bronchi or intercostal vessels. The amount of massive hemothorax is a commonly question asked. When to say massive hemothorax, the amount should be more than 1,500, more than 1,500. This is also an important question asked. Okay, the patient will need a rapid, urgent intervention like clamshell thoracotomy. Clamshell thoracotomy. Okay. Also, there are some investigations done like video-assisted thoracoscopy, which can also help in that. I said video-assisted thoracoscopy and clamshell thoracotomy. Now, I'm going to send indications of emergency thoracotomy. Indications are cardiac tamponade diagnosed rapidly on ultrasound with no obvious non-survivable injury, or unresponsive hypotension with systolic blood pressure less than 70, or initially more than 1,500 milli from the chest immediately. Another indication also is asked where there is blood more than 200 per hour for successive 2 to 3 hours. Okay. Another important photo like that. This also indication for surgery after tube thoracotomy, when to do emergency thoracostomy or thoracotomy of the patient. Massive hemothorax, I said, more than 1,500 on initial drainage, or even more than 200 milli per hour for the first 2 to 3 hours. This is also common question asked. Okay, another indications are increasing the size of the hemothorax on chest field, persistent hemothorax after 2 functioning tubes, clotted hemothorax, leaking ear, and this is also an important question asked. Leaking ear. What is a leaking ear? Means that there is tracheobronchial tree injury. Tracheobronchial tree injury. This is also important question asked. Okay, another one. This Perhaps syndrome. Perhaps syndrome, spontaneous rupture of the esophagus, which occurs due to sudden, severe, increased intraesophageal pressure, causing spontaneous rupture of the esophagus. The patient will present by what's called macular triad. Macular triad is also an important chest pain, vomiting, and subcutaneous emphysema. This is also important question asked. Macular triad of Perhaps syndrome. The patient will present by ear within the mediastinum, like you see in the right arrows in the right side, and the patient is treated by broad spectrum antibiotic due to fear of mediastinitis and the surgical consultation. The most important question asked here is the Hamann sign. What is the Hamann sign? Hamann sign is mediastinal crunching or even crunching sound on inspiration or taking the air. This is Hamann sign. Okay, Perhaps syndrome. Differential diagnosis of Perhaps syndrome. We have another syndrome which is called, commonly asked, Malory. Like that. This is a Malory West syndrome where there is tear of the gastric side of the gastroesophageal junction. Superficial mucosal tear of the gastric or esophageal mucosa, and most commonly to the distal esophagus. The patient will present by hematemesis due to superficial tear and can be managed conservatively. But in Perhaps syndrome, where I said this is Hamann sign on auscultation due to presence of the pneumomediastinum, like that. This is the Hamann sign. The patient will present by the macular triad, chest pain, spontaneous emphysema, plus vomiting. Okay, Perhaps syndrome and Malory West syndrome. Another picture like that. This is macular triad, vomiting, chest pain, and subcutaneous emphysema. Can be misdiagnosed with perforated peptic ulcer, MI, pneumonia, pulmonary embolism, aortic dissection, and pancreatitis. Another condition, this is also a question asked, amputated fingers, how to deal with it. The finger which is amputated is put in a saline soaked gauze and put it in cold with ice. Okay, saline soaked gauze and cooled with ice. This is the deal with the amputated finger. Another one. This is a very important topic, tension pneumothorax. What are the causes of tension pneumothorax? The most common is penetrating chest injury, which form a valve allowing air to pass into the chest, but not allow it to go out. So here, the patient take inspiration, so air goes inside the chest, and with expiration, no air outside. Here, increased the intrapleural pressure more and more, with more and more increase, causing shift of the mediastinum to the opposite side. And the side of the pneumothorax will be hyperresonant. So when you see in the question, hyperresonance of the chest, then absent breath sound, then shift of the mediastinum to the opposite side, these are the criteria of the tension pneumothorax. Valve-like action due to penetrating chest trauma, causing shift of mediastinum, causing tracheal also shift, and causing lung collapse on the same side, and the patient will present by absent breath sound on the same side of the tension pneumothorax and hyperresonance. What's your immediate management of tension pneumothorax? What's called needle thoracostomy or needle thoracocentesis. Needle thoracostomy or needle thoracocentesis. This is wide pore needle or wide pore cannula. You urgently insert it in the specific site for thoracostomy, needle thoracostomy or tube thoracostomy. The new updates, the both of them, either needle thoracostomy or tube thoracostomy, will be in the safe triangle at the level of the fifth intercostal space, mid-axillary line, just anterior to the mid-axillary line, in order not to cause injury of the long thoracic nerve of Bell or nerve to serratus anterior, C5, 6, 7. Okay? Again, how will you immediately manage tension pneumothorax? Immediately insert wide pore cannula or wide pore needle into the safe triangle of the needle thoracocentesis or the tube thoracostomy. It is the fifth intercostal space, mid-axillary line, or just anterior to the mid-axillary line, to avoid injury of the long thoracic nerve of Bell. Okay? And this is also a common question asked. Tension pneumothorax. This is an important picture regarding blowout fracture of the eye. When you direct trauma to the orbit, causing blowout fracture. Blowout fracture is fracture here, which most commonly to occur in the thin orbit floor and causing injury to the ethmoid sinus and the maxillary sinus. Blowout fracture. The thinnest part of the orbit is the inferior orbital floor and injury to the ethmoid sinus and the maxillary sinus. The patient will present by this triad, enophthalmos, diplopia, and ophthalmic lesion. This is an also question asked. Blowout fracture of the orbit. Another one. This is a safe triangle for insertion of chest tube. This is our triangle. Like you see, this is the triangle. Here is the pectoralis major, and here is the latissimus dorsi. The apex of the triangle is the axilla, and at the level of the nipple, just above the level of the nipple, at the level of the fifth intercostal space. Anterior to mid-axillary line. Anterior to mid-axillary line. Another one. What's called blast injuries. Blast injuries, there are 4 phases: primary, secondary, tertiary, quaternary phases of blast injury. The primary, you will know the type or the phase and just one information about everyone. Okay, then the primary blast injury, which occur due to just single information, direct effect of the pressure waves. Direct effect of the pressure waves by the traumatizing agent. This is a blast injury. Primary, secondary, tertiary, quaternary. Primary is direct effect of the pressure waves. Then secondary, tertiary, quaternary. Here, this is secondary, which occurs due to flying debris or the fragments. Flying debris or the fragments. These are secondary to the traumatizing agent, where the first is a direct wave injury, secondary from the flying debris and causing secondary waves, while the tertiary can occur from the individual to be thrown away or thrown into the blast, from the person being thrown into things by the blast, while quaternary by any blast that not due to other three phases. Any blast injury not due to other three phases, not due to direct wave, not due to flying debris, not due to being thrown into things by the blast, like burn, crush injury, and worsening of pre-existing condition. And also due to burn and crush injury, there will be hyperkalemia, and I will discuss it now. Okay, hyperkalemia. This is what are the causes of hyperkalemia, which are collected in the word machine. The most important question asked in hyperkalemia is burn, which can cause cellular destruction, and then hyperkalemia increase the potassium level. M for medication like S inhibitor and non-steroidal. Acidosis causing hyperkalemia due to presence of the hydrogen potassium channel. Usually the body secretes hydrogen outside, but reabsorb potassium. In case of acidosis, there is increased hydrogen in the blood. So the kidney tends to secrete hydrogen outside and retain potassium. So when acidosis, there is increased secretion and retain of potassium. Retain of potassium causing hyperkalemia. This is also important. Cellular destruction, like burn, hypoaldosteronism, because aldosterone itself causing salt and water retention, sodium and H2O retention, and hypokalemia. When aldosterone is decreased, there is hyperkalemia. Excessive intake, nephrons in case of renal failure, and impaired excretion, retainer of potassium. Causes also of hypercalcemia, which are collected in the word chimpanzee. Chimpanzees, this is calcium supplementation, hyperparathyroidism. The hyperparathyroidism, the most common hyperpara is primary hyperparathyroidism due to parathyroid adenoma. The most commonly is parathyroid adenoma. Then I for iatrogenic, M for multiple myeloma. Multiple myeloma is a B plasma cell neoplasm, myeloid line neoplasm, characterized by hypercalcemia and renal failure. Then parathyroid hyperplasia or adenoma. This is like hyperparathyroidism, parathyroid adenoma. Alcohol, neoplasia like lung cancer is also important due to release of hormone-related peptide. This is lung cancer. Zollinger-Ellison syndrome, excessive vitamin D and A, and sarcoidosis. These are the causes of hypercalcemia. It's also important question asked. So hyperkalemia is machine and the hypercalcemia is chimpanzees. Okay. These are some tricks. Do you know Simmons test or Thompson test in the trauma? When the patient has trauma to the Achilles tendon Achilles, which is inserted into the calcaneus. This is the tendon of the triceps shuri muscle. What are the triceps shuri muscle? They are the gastrocnemius and soleus, muscles of the superficial posterior compartment of the leg. When it ruptures in middle-aged men, 4 to 6 centimeters above the calcaneus, the patient is set prone or sit on the chair, and you will do the test, which is called Simmons or Thompson test, by squeezing the calf muscle only. When you squeeze your calf muscle while you are sitting on a chair, there is plantar flexion. Loss of this plantar flexion is an indicator of Achilles tendon injury and this is a positive Simond or Thomson test. This is also an important question in examination station in OSCE Part B. Simond test for assessing the integrity of the Achilles tendon. Another one, this is our last one. Simple information. When the patient in the trauma is given immediately IV crystalloids, you will give crystalloids like Hartmann or Ringer lactate. Okay, Hartmann or Ringer lactate. They are the important crystalloids at the emergency. But here, there is simple information that 1 liter of saline, okay, gives you volume expansion like 200 milli of gelofusine. Okay, gelofusine are large colloid. Okay, are large colloid. So they are exerting a very high osmotic or oncotic pressures. So 1 liter of saline equals 200 milli of gelofusine. Okay, then now I am going to discuss the questions. Hope to finish them all today. Question 1, who wants to participate, please raise your hand. Okay, here you are, Dr. Mehidi. Welcome.
Welcome. Assalamu alaikum, Dr. Hesham. How are you?
Hello, how are you? Nice to meet you, doctor. Okay, then you are ready?
Yeah, I'm ready.
Okay, let's go.
A 27-year woman involved in a road traffic collision after riding her motorcycle into an oncoming tractor. A hemothorax is suspected and surgical chest drain inserted. Which one is the following statement is an indication of a thoracotomy? Chest pain, continued bleeding of over 200 ml per hour for next 2 hours, greater than 500 ml in initial drain, greater than 750 ml in initial drain, pneumothorax. It's option B, continue bleeding over 200 ml per hour for next 2 hours.
Okay, that's right. Excellent. Well, can you tell me what are the other indications of immediate clamshell thoracotomy?
Yeah, initial drain 1500 ml in initial drain. Then, sorry, I can't tell.
Okay, as I told, the patient has present with an immediate severe hypotension with systolic blood pressure less than 70. Then the patient with immediate blood volume in the drain about 1,000 to 1,500. The patient with continued bleeding, as I told, like that, with 200 milli per hour for the next 2 to 3 hours. Okay, these are indications of immediate clamshell thoracotomy. Another question. Okay.
A 40-year-old man present to the emergency department with a Leaford type 3 fracture. His airway is obstructed and you are unable to disimpact the facial bone forward. What is the best way to secure the urgent airway? Bag and mask, chin lift, cricothyroidotomy, oropharyngeal airway, nasopharyngeal airway. I will prefer option C, cricothyroidotomy.
So you go directly for surgical airway protection. Why didn't you choose oropharyngeal or nasopharyngeal airway?
As unable to disimpact the facial bone forward. This is the point which forced me to choose surgical option.
Okay, then the patient has facial bone fracture and Leaford 3 fracture. This is what's called a flat face, craniofacial dissociation. So the best to urgent secure his airway is cricothyroidotomy. You think that?
Yeah.
Okay, who agree with that? Regarding cricothyroidotomy is indicated once you are going through the pattern of initially chin lift and jaw thrust, then oropharyngeal and nasopharyngeal airway then intubation. Later on, I am going to do cricothyroidotomy and tracheostomy. Okay. Then initially, to secure an urgent airway is the oropharyngeal airway. Okay. This is initially to secure the airway. This is an oropharyngeal. Okay. So our answer will be D. Another one. Third question.
Okay. A patient is recovering from an emergency laparotomy in HDU. They have had an adhesionolysis for the small bowel obstruction. No resection was required. Which of the following metabolic changes occur in the EBV phase first 24 hours in response to the injury? Plasma pH increase, the plasma level of the free fatty acid increase, hypoglycemia, the plasma level of the non-protein nitrogen decrease, plasma cortisol increase. Plasma cortisol increase. I'll choose option E.
Yes, that's right. We have two phases in any trauma or any stress surgical conditions. They are called the ebb phase and flow phase. Ebb phase and flow phase. In the ebb phase, we are stressed to cause release of the neurological factors and hormonal factors. Hormonal factors, all of them are anti-insulin. So there is a state of hyperglycemia, and there is release of corticosteroids, catecholamines, and growth hormone. So cortisol level is increased. That's right. Correct answer here is E. Another one. This question. Okay, Dr. Mehdi.
Okay. A 17-year-old man is injured during a road traffic collision. Clinical examination reveals reduced breath sound and hyper-resonant percussion. His trachea is deviated to the left. Where is the correct place to insert a definitive chest tube? Tube thoracostomy. Fifth intercostal space, mid-axillary line, left costal wall. Fifth intercostal space, mid-axillary line, right chest wall. Fourth intercostal space, mid-axillary line, left chest wall. Second intercostal space, mid-clavicular line, right chest wall. Sixth intercostal space, anterior axillary line, left chest wall. It obviously in the right chest wall as mediastinum is deviated to the left side, and it is fifth intercostal space, mid-axillary line, right chest wall. I will prefer option B.
Yes, right. That's right. We have tension pneumothorax on the right side. So an urgent immediate needle thoracostomy followed by tube thoracostomy within 30 minutes. So tube thoracostomy better to be done in the safe triangle, which is bounded by pectoralis major, latissimus dorsi, and the level of the nipple, fifth intercostal space, just anterior to the mid-axillary line to protect the long thoracic nerve of Bell. That's right. Another one. Okay, go on.
It's loading. Actually. Okay. A 25-year-old footballer present with pain in the leg after being kicked during a tackle. There is bruising over his posterior aspect of his leg, which is tense, swollen, and tender. He reported altered sensation over the dorsum of the foot. Foot dorsiflexed and toe extension are painful and limited. He had normal posterior tibial and dorsalis pedis pulses on presentation, but this soon become difficult to palpate. Plain radiograph show no fracture. Which one of the following option is the most appropriate cause for the patient's signs and symptoms? Deep vein thrombosis, torn muscle valgus of gastrocnemius and soleus, compartment syndrome, ruptured Achilles tendon. Though there is no fracture, but pain during foot dorsiflexion and toe extension, passive extension and painful limit. I will prefer compartment syndrome for this question.
Yes, that's right. We have discussed before compartmental syndrome, where there is an increased intracompartmental pressure more than 25. Or there are two criteria for compartmental syndrome, another two criteria. What is the difference between the diastolic and the compartmental pressure is less than 30. The difference between diastolic pressure and compartmental pressure less than 30. Okay, this is also another indication. What are the features of the compartmental syndrome? Pain out of proportion to injury, pain on passive movement of the joint, later on tingling, numbness of the limb due to nerve hypoxia, later on, and this is the last phase of compartmental syndrome, is pulseless pale limb, absent of peripheral pulsation. Urgent fasciotomy is rarely needed when the pressure increased more than 25 and in some boxes reached 30. Okay, and here the answer is compartmental syndrome. That's right. Another question. Okay, this one.
Okay, slowly. A 55-year-old man sustained a femoral shaft fracture in a road traffic collision. He arrives in the emergency department with a heart rate of 130 beats per minute and blood pressure 70 by 40 millimeter mercury. If he is given a 500 ml intravenous bolus of 0.9% saline, what is the most probable outcome? This patient's central venous pressure would be around 10 centimeter water before the bolus. There will probably be an initial rise and then fall of the central venous pressure. There will produce the same intravascular expansion as 2 liter of 0.9% saline. This will produce a sustained central venous pressure rise of more than 4 centimeter water. And last option I can't see actually. But can you please tell me what is the option E?
Okay, I'm going to tell you. Okay, 5% dextrose will produce a volume expansion of 500 millisaline.
Oh, it's false. There is a ongoing patient is hypotension and there is maybe ongoing hemorrhage. So there is probably option B. There will be probably an initial rise and then fall of central venous pressure.
Okay, that's right. When you give the patient 500 milli IV bolus, bolus is causing stretch of the myocardium. The more stretch, the more power and the more pump of the blood. And here is, there will be slight increase of the cardiac output with the central venous pressure also will be increased. Initially, later on, it will be decreased because the 500 milli IV bolus are not the main management of this patient, because the patient is type 3 to 4 shock, because the blood pressure is decreased and the heart rate is 130. This is a class 3 shock. Class 3 and the class 4 management is usually blood plus crystalloid, but the main is blood. As I told you before, we can give the patient whole blood or platelet to fresh frozen plasma to pack the RBCs by 1 to 1 to 1. Platelet to fresh frozen plasma to pack the RBCs by 1 to 1 to 1, or even I give the patient whole blood transfusion. So this is an initial rise of the central venous pressure. Later on it decreases until appropriate management of the condition. Another one, this question.
Okay. You are the orthopedic junior doctor on call and you are blipped to be the resuscitation area on the emergency department for a trauma calls. A 25-year-old man who has been involved in a road traffic collision in the airlifted to hospital from a rural location. During the primary survey, assessment and resuscitation of any trauma victim, which one of the following options should you keep in mind? A cervical spine fracture can be excluded by neurological examination. Approximately 25% of the cervical spine fracture are missed on lateral cervical spine view, and inspired concentration of the oxygen 0.95 is recommended. And then hypotension should be assumed to be due to hypovolemia. Option D is false. It's for actually hemorrhage. I can see option E.
Yes.
And I have no idea with this other option actually.
Okay, this is a primary survey and you resuscitate any trauma patient. Which one of the following options should you keep in mind? Any cervical spine can be excluded by neurological examination. You can exclude cervical spine injury by only neurological examination. No, if neurological examination is free, patient also may have slight tenderness on the cervical spine. This is an indication of doing CT on the cervical spine, or slight lump or limited mobility of the cervical spine. All of them are indications of CT cervical spine. So option E is wrong. Okay, 25% of the cervical spine fracture are missed on lateral cervical spine view. Not this percent, they are less. Inspired fraction of oxygen of 0.95 is recommended. No, it is about 0.8. Hypotension can be assumed due to hypovolemia. Hypovolemia causing hypotension, yes, can be assumed due to hypovolemia. Okay, so option D is right.
Okay.
Another one like this. Okay, I think it's easy. An easy question.
It's loading. Okay. A man is treated with a right-sided intercostal chest drain for the hemothorax after a road traffic collision. He is subsequently develops a winged scapula on his right side. Which of the most likely long thoracic nerve is injured here during insertion of the chest tube? Option B, long thoracic nerve.
Yes, excellent. Simple question. Insertion of the chest tube for fear of the long thoracic nerve of Bell or nerve to serratus anterior, C5, 6, 7. Injury of this nerve causing winging of the scapula of the same side, ipsilateral winging of the scapula. Okay, another question. This one.
Okay. A 77-year-old woman develops central chest pain 2 days following a surgery for a fractured neck of the femur. Her temperature is 37.7 degrees centigrade, heart rate on beat per minute, and respiratory rate 28 breaths per minute. Other results show white blood cell count 9 into 1009 per liter. It's normal. Oxygen saturation 99% on room air. It's also normal. What is the most probable diagnosis? Okay. Patient came with heart rate and respiratory rate 28
Okay,
breathing.
here
Okay,
you are
can you
the
please
options.
show me option, please?
Okay, here you are. What is the most probable diagnosis?
Pulmonary embolism, sepsis, musculoskeletal chest pain, SIRS, secondary to myocardial infarction, aspiration pneumonia. It's most probably pulmonary embolism because during sepsis there is either WBC count is more or less, musculoskeletal chest pain is unlikely here. I will prefer pulmonary embolism because patient has undergone a femoral neck surgery most probably.
So you are okay with pulmonary embolism. Let's go back for the data again. Here you are. Okay, before that, can you tell me what are the criteria of systemic inflammatory response syndrome?
Systemic inflammatory response syndrome, actually there is a temperature, high temperature, then tachycardia, tachypnea, and
temperature more than 38, and the
38.
patient here is 37.7, so not from SIRS. Heart rate
more than 90 beat per minute in case of SIRS.
This is one. Okay, we have one.
This is to fill the criteria. And
respiratory
tachypnea, respiratory rate is more than 25.
Okay. These are two criteria. Okay, what about TLC?
Total count either 11 more than 11,000 or less than 4,000.
Okay, so I have 2 from 4 criteria, and these are positive with SIRS. So the patient has systemic inflammatory response syndrome. Okay, please
Oh,
keep it.
okay, okay. Got it.
Okay, this is also an important question. Please keep
Got
it.
it.
This is tricky like exam questions.
Yeah, sure.
Okay, another question. This one, your last question.
Okay,
Acid base.
it's loading. A patient is admitted to the intensive care unit with a severe head injury following a road traffic collision. Vital observation are heart rate 90, blood pressure on 22/79, respiratory rate 7, saturation of oxygen 100 on 15 liter oxygen via the non-rebreathable max. The Glasgow Coma Scale GCS 10 CT head shows a large extradural hematoma. What is the most likely acid-base disorder? Here, patient is hypoventilated, respiratory rate 7.
Yes,
Patient that's why I can go for respiratory rate 7. Hypoventilation cause retention of carbon dioxide, which means increase carbon dioxide and decrease the pH. So respiratory acidosis I will go for.
yes, excellent. This is the respiratory acidosis. Okay, that's right. Because hypoventilation and bradypnea, so the patient will be CO2 retainer, increase the CO2 causing respiratory acidosis. You have to remember extradural hematoma. Extradural hematoma is characterized by lucid interval. What is the lucid interval of extradural hematoma? The patient regains consciousness after the onset of trauma has been disappeared. Initially, when the patient is traumatized to his head, he lost consciousness due to brain concussion. Later on, after the onset of the trauma has been removed, the patient regains his consciousness. But after a while, the patient loses consciousness again. Why? Because the blood has been accumulated in the extradural space and causing pressure to the brain. Okay, this is also important. Extradural hematoma characterized by lucid interval. Okay,
Okay.
another picture. Okay, we discuss this question, and I am going with Dr. Saleha after you. Okay, go on. Okay, ready, Dr. Saleha.
Yes, sir.
Okay.
Assalamualaikum, everyone. A 23-year-old man is brought into the accident and emergency department as a trauma call after being stabbed in the neck by a rival gang member. The knife has been left in a place and is entering through sternocleidomastoid on the left below the cricoid cartilage. His heart rate is 80 beats per minute and a blood pressure is 140/90. He is alert and able to speak in sentence. And what is your management plan? Barium swallow, CT, angiogram of the head and neck, endoscopy, immediate transfer to theater for exploration, and remove knee in AN bag wound. I will go for B.
Yes, excellent. This is zone 1, neck trauma. I said
Yes.
before, if there is any trauma to zone 1, 2, 3, you are going to CTA, CT angio. Okay? This is a simple question. Another one.
A 27-year-old is brought into an emergency department by ambulance following a high-speed road traffic collision. They are brought in by an inexperienced paramedic crew who had not provided any cervical spine immobilization. What is the best method to immobilize his cervical spine? With a rigid collar in all patients involved in traffic collision of over 30 miles per hour, with a soft collar in all patients with a blunt trauma above the clavicles, with a rigid collar, sandbags, and cap in all unconscious blunt trauma patients in the position that it is found until a fracture has been excluded radiologically, manually with inline traction until it has been secured with a I will go with C, with a rigid collar, sandbags, and tap in all unconscious blood trauma patients.
Yes, excellent. This is a triple immobilization of the cervical spine. And this is with A, is airway, patient with advanced trauma life support, assessment of the airway and cervical spine immobilization by triple immobilization. Okay, rigid collar, sandbags, and adhesive tape. Okay, I'll share a photo like that. You see that? Here is the stiff neck collar, and this is the adhesive tape and the sandbag on both sides of the head. Okay.
Okay.
Another question. This is a good one.
You respond to a trauma call. The patient has bilateral chest drain inserted and has lost 100 ml of fresh blood into one and 750 ml of fresh blood into the other. The patient has a pulse rate of 80 beats per minute, normal pulse rate 60 to 100 beats per minute. Which one of the following could all contribute towards suppressing the tachycardia response despite such significant hemorrhage? Hyperthermia, a pacemaker, a blocker, and calcium antagonist. Hyperthermia, a pacemaker, beta blockers, and calcium antagonist. Hypothermia, a pacemaker, a beta alpha blocker, and calcium antagonist. Hypothermia, a pacemaker, beta blocker, and calcium antagonist. Hypothermia, a pacemaker, beta blocker, and dopamine. Sir D.
So the patient has hemorrhage. What are the causes of tachycardia? I'm going with hypothermia, pacemaker, beta blocker, and the calcium antagonist. So the correct answer here is D. Okay, hypothermia, pacemaker, beta blocker, and the calcium antagonist. Okay, good question. Another one. This one, simple.
A 21-year-old man is brought to the emergency department unresponsive after being stabbed in the chest. The knee has been left in place and entered the fourth intercostal space on the left of the sternum. His heart rate is 140 beats per minute and blood pressure is 70/30. Examination reveals a central trachea and distended neck veins. He has a normal brace sound but muffled heart sound. What is the most likely diagnosis? Aortic dissection and cardiac tamponade, hemothorax, pneumothorax, tension pneumothorax. Sir, it's cardiac tamponade.
Yes, there the PEX triad of cardiac tamponade. Congested neck veins, it is found. Muffled heart sound is present.
Muffled heart.
And the hypotension. Hypotension, distended neck veins, and the muffled heart sound. 3 of PEX triad. Another question. This one.
A 14-year-old girl fell off her scooter and was not wearing a helmet. Her mother says she lost consciousness for a few minutes and vomited several times. In emergency department, she is drowsy and can't remember the event leading to the accident. She also reports neck pain and tender over C5 and C5 to C7. What is the most appropriate investigation in her management? CT scan, head and cervical spine. CT head, no images required, skeletal survey and skull x-ray. Sir, I will go for A because history of head trauma, vomiting, and loss of consciousness.
Yes, excellent. We want to do a CT brain for the patient. I'm going to do a CT because the patient has lost consciousness for even minutes and vomited several times. Okay, this is an indication of the CT. That's right. Another question. This one.
A patient is involved in an RTA. They have had several trauma to right lower limb. Imaging demonstrate a displaced and comminuted mid-shaft femoral fracture. The acute phase response seen following a lower limb injury can include which one of the following options? increased insulin levels, increased liver glycogen levels, increased plasma catecholamines, reduced plasma fatty acid, relevant hypoglycemia. In acute response phase, there is always increased plasma catecholamines.
Yes, that's right. Here is the release of anti-insulin, so the insulin level is decreased. Here is the phase of trauma, where the glycogen is depleted, so glycogenolysis is needed. Here is the increased plasma catecholamine is right. Plasma-free fatty acids are increased, not decreased, and the patient will be in a state of hyperglycemia due to release of anti-insulin. Okay, so the correct answer here is C. Another one. This question.
A motorcyclist who had been involved in a high-speed accident was brought into a major trauma center, intubation and ventilated with a full spine protection. He was unconscious. After examination, he was noted to have priapism and did not respond to painful stimuli below the clavicle, but did respond above the clavicle. The team leader suspected a cervical cord injury. What is the most likely reason for this suspicion? Given the mechanism of injury and suspicion of spinal cord injury, plain radiographs of the C-spine should be taken. Pre-hospital care teams can cause cervical cord injuries when removing the helmets of injured motorcyclists. The patient had a blood pressure of 80 by and heart rate of 100.
I'll send another options. I'll send the other options.
Okay.
Okay. Okay.
The patient had a blood pressure of 80 by 50 and heart rate of 100 beats per minute. The patient had increased upper body tone. The patient had priapism and grimace when given a painful stimulus above the clavicle but not below it.
Okay, this is a difficult question. Due to cervical spinal cord injury, I am going to clarify it. Okay, cervical spinal cord injury, I'll send a picture of it. Here is the patient with trauma to the cervical spine and injury to the cervical spinal segments. You must know that C3, 4, 5 are phrenic, so they are causing diaphragmatic paralysis. So the patient will be on ventilation due to diaphragmatic paralysis. This is initially. Later on, once the patient has trauma to the spine of the cervical spine, so there is complete paralysis below the level of lesion. Complete paralysis below the level of lesion. So his both upper limbs and the both lower limbs will be paralyzed. The patient will present by quadriplegia. Okay, then later on, the patient lost the sympathetic supply. So the parasympathetic will be dominant. Parasympathetic will be dominant. So the patient will present by priapism. Priapism, painful sustained erection due to increased vascularity in the corpora. This is the level of injury above the clavicle and with the upper 7 cervical vertebrae. Criteria will be injury to C3, 4, 5. The patient will have diaphragmatic paralysis, quadriplegia, and priapism. Okay, this is also an important question. So your answer here will be the last one. I will send the options again. The patient has priapism when given a stimulus above the clavicle. Okay, but not below it. This is also an important question. Please focus. Cervical spine segment injury. The patient has C3, 4, 5 phrenic nerve injury, diaphragmatic paralysis, respiratory failure. So the patient will need mechanical ventilation, endotracheal intubation. Okay, then also there will be priapism due to loss of the sympathetic supply and the dominant parasympathetic. okay, and dominant parasympathetic supply. So there will be also priapism. Okay, this is also important question asked. Another one. Like that. I think this is simple about compartmental syndrome. We discussed it. Okay, can you hear me, Dr. Saleha? Can unmute yourself? Okay.
Yes, sir. A 12-year-old child has tibial and fibular fracture following a fall from a swing. The fracture is reduced and placed in an above-knee plaster in the accident and emergency department. What is the most reliable clinical feature for compartment syndrome in this alert patient? Compartment pressure is in excess of 30 to 35 millimeter of mercury in a normally perfused patient. Loss of dorsalis pedis and posterior tibial pulses on Doppler examinations were paired with passive flexion of the foot, palpation of the tension swollen compartment, and fourth one is sensory or motor nerve deficit. Sir, this is C. There is always a pain with passive movement.
Okay, as you see, all of them can be with compartmental syndrome. Loss of pulsation can be seen, but is distal. Okay, tense, swollen also can be found. Okay, but the most reliable clinical feature for this one, the most reliable clinical feature, you should focus with the question. It is a clinical, not an investigation. Here is the first. And the most reliable, this is a late sign. Okay, you have now tense swollen limb and pain on passive flexion. Pain on passive flexion is characteristic of compartmental syndrome. Tense swollen limb may be DVT, may be cellulitis, or compartmental syndrome. So the most reliable clinical feature here is severe pain out of proportion to the injury on passive movement of the joint, severe pain on passive flexion of the foot. Another question, another simple question.
A 25-year-old man arrives in the emergency department following a road traffic collision. He has chest injuries and a chest drain is inserted, draining blood. What volume of immediate blood drainage distinguishes between a simple hemothorax and a massive hemothorax? 1,000, 1,500, 2,000, 2,500, and 3,000. So it's 1,500 ml.
Okay, that's right, 1,500. Okay. Another question, this one.
A 58-year-old man is brought into the hospital after being struck by a van at a high speed. He is short of breath. Blood pressure is 108 by 76. Pulse is 118. Respiratory rate is 22, and oxygen saturation is 88% on 100% oxygen. On examination of his chest, the trachea is deviated to the left, and the right lung is hyperresonant to the percussion. To percuss with reduced air entry. Which one of the following option is the most likely diagnosis in this patient? Pulmonary embolism, tension pneumothorax, diaphragmatic rupture, right main stem bronchus, pulmonary contusion. Sir, it's tension pneumothorax, D.
Yes, excellent. We have 3 criteria of tension pneumothorax, whereas the first one is oxygen saturation is decreased here, and there is deviation of the trachea, and the third one is hyperresonance of the chest, also reduced air entry. Okay, important question, yes. Tension pneumothorax. How will you manage this patient?
Sir, needle tracheotomy. Yet,
yes.
Then afterwards, we'll go with...
it is called needle thoracostomy. Needle thoracostomy. Okay, how will you insert your needle?
A second intercostal space, mid-clavicular line.
You say it second or
intercostal. First? Sir, for needle, we will go for second intercostal space, and for chest tube, we will go fifth intercostal space.
No, please keep it. The last updates, needle and chest tube insertion are at the fifth intercostal space. Please keep it. Nothing now at the second space. Sir. All questions will be at the fifth intercostal space in the safe triangle, just anterior to the mid-axillary line. Okay. needle thoracostomy or thoracocentesis, not thoracotomy. Thoracotomy is an incision. It is a thoracostomy or thoracocentesis. Okay, another one. Okay, your last question, Dr. Salaha.
Okay, sir. A 47-year-old motorcyclist is involved in a head-on plane at 85. On arrival to the emergency department, his systolic blood pressure is 60 despite fluid resuscitation, and heart rate is 180 beats per minute. Primary survey revealed no injuries. Chest and pelvic x-rays are normal. The assessment after x-ray reveal a generally peritonitic abdomen. What is the next best investigation or management step? CT scan, diagnostic peritoneal lavage, 4-quadrant cap, laparotomy, ultrasound in the radiological department.
Okay, what do you think? Here is a tricky question. What is the next best investigation? Here, no time for investigation. The patient in class 4 shock. 180 and systolic blood pressure is 60. So 60. No investigation. Here I will go for laparotomy. Okay, there is no time for investigation. Yes. Okay, even you do the fast, you will take the patient immediately to laparotomy. Okay, another question. Okay, another one, Dr. Salaha. You will be with, I think, Dr. Noor Alam. Are you ready?
Sir. Yes, sir.
Hello,
I'm ready,
Dr.
sir. Hello, sir. A 19-year-old man is stabbed in the back and has some neurological changes. Imaging shows he has suffered a left hemi-section of his spinal cord at the T5. Which of the following finding is most likely? So it is Brown-Séquard syndrome. There is a loss of ipsilateral ankle jerk, a loss of pain in the ipsilateral foot, Babinski sign in the ipsilateral foot, D, preservation of fine touch sensation in the ipsilateral foot, wasting of the contralateral quadriceps muscle. Sir, there is a loss of pain temperature in the ipsilateral foot, sir. No, loss of.
Okay, take your time and focus. It's a Brown-Séquard syndrome. Okay, there will be ipsilateral and contralateral. The thing which is found contralateral is pain and temperature. Okay, the lateral spinothalamic tract are in the opposite side. On the same side, there will be posterior column, which is pain and which is tactile sensation, pressure, and position. This is a posterior column, and the pyramidal tract. Okay, and the pyramidal tract. Okay, pyramidal tract is the corticospinal tract of motor. So the patient will have upper motor neuron lesion. The upper motor neuron lesion is positive Babinski sign. Again, this is a hemisection of the spinal cord. The patient will present by contralateral features and ipsilateral features. Contralateral features will be the spinothalamic tract, pain and temperature lost on the opposite side. But in the same side, there will be two lesions, posterior column, loss of pressure, tactile sensation, and proprioception, and also loss of the corticospinal tract with the pyramidal tract, upper motor neuron lesion. So the patient will have lost Babinski on the ipsilateral foot. Okay? This is also an important. Please keep it. Important question. Very important one. Okay. Another question. Are you okay?
Yes.
Dr. Noor?
It's loading.
Okay.
Sir. Yes, sir. You are awaiting the arrival of a patient for whom there has been a trauma call. The details already known are that the patient is a 23-year-old man who has been involved in a high-speed motorcycle collision and who has an obvious open mid-shaft left tibia fracture. What is the first thing you should do when the patient arrives? Application of a plaster backslap, assessment of the patency of the airway, assessment of respiratory rate, a photograph of the wound, a saline show dressing for the wound. Sir, we'll go for ATLS guideline. If you go for ATLS guideline, then first would be airway patency. So it should be B, sir.
Yes,
assessment of the patency of the airway.
Excellent. This is a polytrauma patient. he is trying to tell you that there is a mid shaft fracture. So initially you will go for assessment of the fracture or even saline soaked dressing. But please don't forget the advanced trauma life support. The patient should assist according to ETLS. I should assess patency of the airway and cervical spine immobilization, triple immobilization. So please focus. Some questions are tricky like that. So you will assess the patient. The first thing to be done for the patient is assessment of the airway. Another question. This one.
Yes, a 25 years old motorcyclist suffered an unwitnessed high-speed collision as suggested from damage to his helmet and vehicle and present with a GCS of 10. There are multiple bruises to the head, chest and abdomen with a normal limb appearance. He is hemodynamically stable. What should be the initial investigation of the patient include? Trauma series, CT scan of the head, cervical spine, chest, abdomen and pelvis, insertion of a intracranial pressure monitor, a lumbar puncture, chest, abdomen and pelvic radiograph. And E option is not visible, sir. Since the patient is stable, sir, we can go for because there is a blunt trauma abdomen, blunt trauma chest, and injury to the head. We should go for a CT scan of the head, sir, heads, chest, abdomen, and pelvis, sir.
Yes, patient is hemodynamically stable. Okay, so the primary survey has been done. So we will go now for the secondary survey, head to toe examination and investigation. So I am going to do CT scan of the head, cervical spine, chest, abdomen, and the pelvis because the patient has multiple bruises to the head, chest, and abdomen. Okay, that's right. So the correct answer here is A. Another one. This one.
A 25 years old man sustained a stab wound to the lateral aspect of the thigh. The police report that the weapon used was a homemade knife. After initial assessment and resuscitation, CT imaging does not demonstrate femoral vessel disruption, but evidence of superficially retained knife fragment. What is the most appropriate next step in its management? The fragment removal and discharge, wound closure in the accident and emergency department. C, patient can be discharged without the need for any intervention. D, surgical exploration of the femoral vessel. E, tetanus prophylaxis and antibiotic. Sir, the CT scan has been done and the femoral vessel is not damaged. And so, sir, it should, but it's a homemade knife, so it is not a sterile, so it should have tetanus prophylaxis. It should be E, sir, tetanus prophylaxis and antibiotic.
Okay, yes, that's right.
There,
tetanus prophylaxis and antibiotics and local wound exploration. Okay, here is a superficially retained knife, and you have the most important investigation, CT angio, has been done and does not demonstrate any femoral vessel injury, like femoral artery or femoral vein. So this is an exact investigation with no need of surgical exposure of femoral vessels. Here I am going to do tetanus prophylaxis according to the vaccination schedule, antibiotics and local wound exploration only. No need to explore the other vessels. Okay, another question. This one.
A 23 years old man is brought by his friend into the emergency department after falling downstairs on leaving a nightclub. On examination, he is slightly drowsy, smelling of an alcohol and complaining of neck pain. What should be the immediate management of this patient? A, analgesia, C, B, cervical spine immobilization, C, immediate head and neck CT, D, IV access and fluid resuscitation, E, IV paraben. So it should be a cervical spine immobilization for ATLS guideline, and because patient is also complaining of neck pain and injury over the neck side.
Yes, excellent. That's right. According to ETLS, I will manage the patient according to airway, that cervical plus cervical spine. Okay, so cervical spine immobilization is an important step. Okay, the patient here is drowsy and alcoholic, and Parpinix here is used in patients with Wernicke's syndrome in alcoholic encephalopathy. Okay, So ETLS, I will go with airway and cervical spine triple immobilization. Another one, this one.
You are on call orthopedic junior doctor and are called to the emergency department to assess an open femoral fracture with active severe bleeding in a 24-year-old man. His BP is 80 by 50 mm of Hg and pulse rate is 210 beats per minute. He looked pale and his peripheral pulse is absent. Which of the following options should be initial management of the fracture? Apply direct pressure to control the bleeding, locate the bleeding point and apply direct forceps. The fracture should be reduced by use of splint. The patient has compartment syndrome. He should go straight to the theater. The patient should be urgently. It should be, sir, first the bleeding should be assessed because there is no airway management or breathing management. So first we have to go for direct management of bleeding. So direct compression to control the bleeding. So A should be the answer, sir.
Yes, excellent. For assessment of the C of Atlas circulation, I am going to do pressure and packing, 2P, pressure and packing. No need for tourniquet. So control immediate or initial control of bleeding is pressure and packing. That's right. Another question. This one.
A young man is admitted to the emergency department resuscitation room in a hypovolemic shock following a stab injury to his abdomen. He is pale and it is clear that he has lost a significant amount of blood. Which of the following changes in cellular metabolism would you expect in these circumstances? Increases ATP production, passage of potassium into the cell, excretion of sodium out of cell, reduce ketone production, accumulation of lactic acid. Sir, it should be the accumulation of lactic acid. Maybe the patient is in shock.
Yes, here the patient is shocked,
Because the
so
patient
the
is in shock.
anaerobic pathway is activated because due to lack of ATP, so ATP is decreased. Okay, and as we know, is sodium is more than outside the cell and potassium is more than inside the cell. So in this condition, sodium will enter into the cell, not out of the cell, and potassium will go out of the cell, not into the cell. And there is increased ketone production. And in this patient, there is a lactic acidosis. Lactic acidosis is two types, type A and type B of lactic acidosis. Type A is perfusion acidosis. Type B is metabolic acidosis. So the patient will has lactic acidosis type B. Okay, excellent. So the accumulation of lactic acid is right answer. Another one. This question. Hello, Dr. Noor. Can you hear me? Okay, I think he has some problem with the network. Okay, Dr. Baida. Are you ready?
Okay, thank you, doctor. A 27-year-old man is brought into the emergency department following a stabbing to his left chest. Absent air entry is noted on examination of his left chest, and it is dull to percussion. The diagnosis of hemothorax is made and chest drain placed. This drain is 1,600 ml of blood immediately, and the patient become more hypotensive. What should be the next step in managing the patient? Blood transfusion and correct anticoagulopathy, clamp the drain, clamshell thoracotomy, inotropes to improve the blood pressure, midline sternotomy. I think it's thoracotomy as an emergency and not to stop the bleeding.
Yes, excellent indication of emergency thoracotomy is initial blood in the drain with 1,000 to 1,500 milliliter or ongoing bleeding about 200 milli per 1 hour for 2 to 3 hours. Okay, then our indications of immediate clamshell thoracotomy. That's right. So the correct answer here is C. Another question. This one.
Okay. A 17-year-old man is brought to the emergency department following a road traffic collision and is quickly diagnosed with the hypovolemic shock. Several attempts at intravenous cannulation are unsuccessful, and so an incision is made anterior to the medial malleolus. Which vessel would be cannulated? anterior tibial vein, dorsal venous arch, long saphenous vein, medial margin vein, and short saphenous. As it's anterior to the medial malleolus, it is a long saphenous vein.
Okay. Are you okay with long saphenous? This is what's called venous cut down. Okay. Venous cut down can be done in children, in emergency, also intraosseous line, cannula within the bone can be also used for resuscitation. Here, venous cut down, we have the great saphenous vein, which is the medial tributary of the dorsal venous arch, which started just anterior to the medial malleolus. Structures anterior to the medial malleolus are long saphenous vein and saphenous nerve. So the correct answer here is long saphenous vein. Excellent. Another one. This question, simple one.
41-year-old man is brought to the emergency department very short of breath. After a road traffic collision, he cannot complete a sentence and his respiratory rate is 34 breath per minute. Examination reveals bruising over his right chest with reduced chest expansion and tracheal deviation away from this side. Percussion is hyperresonant and the breath sounds are absent in the right hand side. What is the most probable diagnosis? It is tension pneumothorax.
Yes, simple. There is reduced chest expansion, tracheal and mediastinal deviation to the opposite side, hyperresonant chest, absent breath sound. 4 criteria of tension pneumothorax.
Okay, can I ask you a question? How to differentiate between it and the flail chest? Because the flail chest, even there is a bruises and fracture of the ribs.
But you will see the segments of the flail chest. Okay, definition of flail chest are fracture of 2 or more than ribs in 2 sides. 2 or more than ribs in 2 sides. You will see the movement. Yes, excellent, Dr. Agada. You will see the movement of the ribs inside and outside with each inspiration and expiration. But in tension pneumothorax, you will not see that. Okay, there will be limited mobility with inspiration and expiration. Okay, that's right. Another question. This one.
A 23-year-old motorcyclist presents with a blunt chest injury and is noted to have hyperresonant and absent breath sound over the right hemothorax, with the evidence of a tracheal deviation to the left. He is clinically shocked. In addition to this, what should be the first clinical intervention? Endotracheal intubation, intercostal drainage, needle decompression, positive end expiratory pressure, ventilation, and thoracotomy. Needle decompression.
Yes, right. Needle thoracostomy or needle decompression in the 5th intercostal space, just anterior to the mid-axillary line. And within 30 minutes, you should put the chest tube, okay? Needle decompression and within 30 minutes, chest tube. Another question. This one.
64-year-old dialysis patient has a large pleural effusion compromising her breathing. They are not safe to be discharged in this current state. Which one of the following option is the most appropriate landmark for the safe area of the chest drain insertion? In the axilla, inferior to the nipple line, mid-axillary line, through pectoralis major and 7th intercostal. This is C.
Okay, this is simple, but please don't confuse with the nipple line because I say it's the nipple line, but it is above the nipple line. Okay? At the level of the 5th intercostal space, above the nipple line, not below. Okay, another one. This question.
Okay. A patient presents as a trauma call with head and facial injury. The radiologist call you to say the patient has a fracture through the superior orbital fissure on CT scan. Which one of the following nerves is most likely to be affected? Optic nerve, mandibular division of the trigeminal nerve, maxillary division of trigeminal nerve, trochlear nerve, and supraorbital nerve. Supraorbital fissure is most commonly comes the V3 and the mandibular division of trigeminal nerve. Okay.
Okay, then please focus. What are the structures which are passing through the superior orbital fissures?
Trochlear nerve, abducent nerve, and it is 3, 4, and oculomotor nerve also.
Yes,
So,
oculomotor,
okay,
superior and inferior division of oculomotor. Then
okay, so
4 and 6, trochlear and abducent. And the ophthalmic. Ophthalmic 3 branches. Frontal, lacrimal, mesociliary branches of ophthalmic of trigeminal. Okay? So
okay.
the correct answer here will
Is
be
D.
trochlear. Trochlear. Okay? Optic nerve passes through the optic foramen.
Okay, foramen.
Mandibular division is V3 in foramen ovale.
Ovale.
Maxillary nerve from the foramen
Spinous
rotundum. Okay, trochlear is superior orbital fissure. Supraorbital nerve, supraorbital foramen. Okay,
Okay.
that's right. Okay, another question. This one.
A 50-year-old man was hit by a car, sustained a proximal fibular fracture at the level of the fibular neck. Following the injury, he had foot drop gait, wasting and weakness of the anterior and lateral compartments of the calf, but the preservation of the posterior compartment muscle. There was a loss of sensation over the dorsum of the foot, including the first web space. Which one nerve is the most likely to be damaged? Common peroneal, deep peroneal, sciatic nerve, superficial. It comes with the common peroneal nerve.
Yes, excellent. Okay. Here, a very important characteristic sign, proximal fibular fracture. The only nerve which is fractured in proximal fibular fracture is the common peroneal nerve. It hooks around the neck of the fibula, then it divides into superficial and deep peroneal nerve. Superficial peroneal nerve supplies the whole foot. Deep peroneal nerve supplies the first interosseous, the first web space. Okay, so here it is the right answer, common peroneal nerve. Please focus. Another one. This one.
Okay. You are attending a trauma call for a patient who has sustained a neck injury.
Okay, excuse me. Dr. Ghada is asking about why not deep peroneal nerve. Deep peroneal nerve is supplying only the first web space, but here there is loss of sensation over the whole foot. So the common peroneal nerve is supplying whole foot. Okay, then you can continue.
Okay, you are attending a trauma call for a patient who has sustained a neck injury. They have been immobilized with the block and tape as a part of the initial management. From the following option, which level of the cervical spine injury would you expect to resolve significant problem with the ventilation? As we see, it's from C5, 3, 4, 5, but
C3,
nerve,
4, 5.
5. Okay,
no, the higher the level.
C4.
No, the higher the level, the more significant the problem. The
okay.
higher the level, the higher the problems. Okay, when I go above, the problems will be significant. Okay. When you see significant problems, so I have C3.
C3.
Okay. Another one. This one.
A 45-year-old woman felt sudden pain at the back of her ankle while playing netball. On examination, she has a positive Simon-Thompson test with the pain on tenderness posterior to the ankle joint. What is the likely diagnosis? Achilles tendon rupture.
Yes, simple question. On squeezing the cuff, no plantar flexion of the foot. Okay. This is Simon test positive. Right. This one.
24-year-old man is rushed into an emergency department after being kicked in the neck during karate competition. He has a hoarse voice and is very short of breath. On examination, there is a marked stutter, laryngeal tenderness, subcutaneous emphysema, and the patient is drooling saliva. What is the first line treatment? nasopharyngeal tube insertion, CT angio of the neck, and emergency tracheostomy, endotracheal tube, surgical cricothyroidectomy. And because it's the neck injury, and so we go CTA B.
Okay, I told before the more important is the airway.
Is Atlas. Okay.
Okay,
Nasopharyngeal.
the airway. So I will go for airway. The most important is airway and cervical spine immobilization. Okay, airway and cervical spine immobilization. Here, the trauma is in the neck. So nasopharyngeal airway will be too short. The trauma is below, so there will be still occlusion below. I will put the nasopharyngeal tube, but it will not give any benefit. Okay, so here
Okay.
the most important is endotracheal intubation and cervical spine immobilization, the first line of treatment. Okay.
Okay. Thank you.
Or last question would be that.
A 33-year-old cyclist is brought to the hospital after being hit by the car at 50 mph, and he has severe bruising over his left chest wall with a puncture wound at the left 6 intercostal space. There is a decreased air entry over the left lower lobe of the lung, and bowel sound are heard in the chest. Chest X-ray reveals a fracture of the left lower 4 ribs with a raised hemidiaphragm. Which one of the following the most likely diagnosis of the patient? It's because there is bowel sound found within the chest, so we go to diaphragmatic rupture.
Yes, excellent. This is a diaphragmatic rupture. Any trauma from 4th to 10th intercostal space raise the suspicion of diaphragmatic rupture. Diaphragm usually like this. When it contracts, it go downward. When it is paralyzed, it go above. So when there is fracture of the lower 4 ribs with raised hemidiaphragm, means it is paralyzed. So there is a diaphragmatic rupture. That's good. And here is the trauma is in the 6th intercostal space between 4 to 10. This raises the susceptibility of diaphragmatic tear or rupture. Excellent.
Okay, thank you.
Thank you, doctor. Okay, Dr. SK. If you are ready.
Yes, I'm ready, sir.
Hello, okay, go on.
Hello, okay. Can't see the question. A 36-year-old woman is struck by a car and is brought to the emergency department complaining of abdominal pain. Examination revealed clear chest, but severe abdominal tenderness once in the left upper quadrant. Patient becomes progressively hypotensive and tachycardic despite aggressive food resuscitation. The urgent review reveals generalized abdominal tenderness with peritonitis. What's the most appropriate management? CT of the abdomen and pelvis, emergency laparotomy. First, emergency arteriography and repeat DPL. I think I'll do a fast.
You will do fast. Okay, then you have the patient who is falling. You
Yes.
have hypotension, tachycardia despite aggressive fluid resuscitation. And you have a mark of clinical peritonitic abdomen, like generalized tenderness and peritonitis. So depending on the clinical, I will do an emergency laparotomy for this patient. Okay. I have severe tenderness in left upper outer quadrant, and I have hypotension and tachycardia and peritonitis. 3 criteria to push the patient for an emergency laparotomy. Okay, another question. This one.
A 33-year-old woman is brought into the emergency department with severe burns. She requires intubation and is admitted to the intensive care unit. Her potassium is 6, normal is 3.5 to 5. In these circumstances, what is her hyperkalemia, most likely due to dopamine infusion, metabolic alkalosis, succinylmethonium chloride administered during rapid intubation, burns, septic shock. I think the answer is D.
B, metabolic alkalosis. So I said before
D.
D.
Burns. D.
Yes,
Yes.
excellent. Okay.
Yes.
This is
Yes.
cellular destruction. I said before hyperkalemia is machine. Okay. Here is the C is cellular
Yes.
destruction.
Yes.
Okay, causing hyperkalemia.
Yes.
Excellent. Another one.
A 45-year-old woman is brought in following trauma call, having been involved in a road traffic collision. On arrival, she's very short of breath and complaining of right chest pain. On examination, she's cyanosed, has absent air entry on the right, and is hyporesonant on percussion. The trachea is deviated from the median. What is the immediate management? Chest drain insertion on the right, chest CT, chest X-ray, needle-thoracocentesis, thoracotomy. I would first put a needle-thoracocentesis, then within 30 minutes, I put a chest drain on the right.
Okay, and this is attention pneumothorax. So the immediate management will be needle thoracocentesis or needle thoracostomy. Excellent. The correct answer here is D.
D, yes.
Okay. This one.
A 22-year-old man arrives in emergency department following a motorcycle accident. His GCS is 7. He has sustained head and chest injuries. You notice dried blood and bruising around the left ear, bilateral periorbital ecchymosis, and blood-stained discharge from his left nostril. What type of airway management would be most appropriate? A is nasopharyngeal airway. B is nasopharyngeal intubation. C, oropharyngeal airway. D, endotracheal intubation. E, cricothyroidectomy. So I would go with D, endotracheal intubation, because of the very low GCS. The patient may not be able to maintain an open airway with the nasopharyngeal or oropharyngeal airway.
Yes, excellent. Here are the indications of intubation. Once 8, intubate. Okay, so once the Glasgow is 8, here it is 7, so it's below than 8. Once 8, you should intubate. Any patient with inability to maintain adequate oxygenation or ventilation should be intubated. Any patient with inhalational burr, prophylactic intubation can be done if there is respiratory distress. Okay, so once 8, intubate. The correct answer here is D, endotracheal intubation. Okay, thank you, Dr. SK, who wants also to participate. Dr. Alkhan, Dr. Agada,
Thank you too, sir.
Already. Thank you.
Assalamu alaikum, sir.
Alaikum assalam. Hello, Dr. Alkhan, how are you?
Yes, sir, I'm fine.
Okay. Are you ready?
Yes, sir.
Okay, this question.
A 30-year-old man admitted having fallen 6 meters, sustaining a significant head injury. They appear confused on initial assessment, and this does not subsequently improve. When managing their intracranial pressure and cerebral blood flow following head injury, which one of the following statement is correct? Cerebral blood flow rises in direct proportion to increase in the systolic blood pressure. No. Hyperventilation increases cerebral blood flow. Yes, it increases, I think. Reduce partial pressure carbon dioxide reduces intracranial pressure. intracranial pressure can be reduced by controlled hyperventilation with for raised blood pressure and tachycardia can sign up elevated intracranial raised blood pressure and in tachycardia sign up elevated intracranial pressure. So I think hyperventilation increases the cerebral blood flow.
Okay, I'm going to clarify that.
Sure.
Okay,
Sir.
I'm going to clarify that, Dr. Khan. The relation between CO2 and the cerebral blood flow. To know, CO2 is vasodilator. This is the
Yes,
initial
sir.
information you should know. Okay, CO2, when increased CO2, there is vasodilatation. So there will be increase the cerebral blood flow. There will be increase the intracranial pressure. And as you know, we have the cerebral perfusion pressure, which is called, okay, you have side noise, Dr. Khan. I'm going to unmute you now for a while,
Yes,
then I will go back with you. Okay, the cerebral perfusion pressure equals mean arterial pressure minus intracranial pressure. Okay, then let's go. If CO2 is increased, so there is vasodilatation. So there is an increase of the cerebral blood flow. So there will be increase in the intracranial pressure. When intracranial pressure increases, so the cerebral perfusion pressure is decreased. So with decrease the CO2, the reverse will occur. So please concentrate. Increase CO2 will cause vasodilatation, increase the cerebral blood flow, increase the intracranial pressure. With increase the intracranial pressure, there is decreased cerebral perfusion pressure. Okay? Then, when there is increase in cerebral blood flow, there will be decrease in cerebral perfusion pressure. Here is flow and here is pressure. So when the patient has hyperventilation, so CO2 is reduced, there will be vasoconstriction. The cerebral blood flow will decrease. Intracranial pressure will be decreased. Okay, so option B is wrong. Reduced CO2 causing reduction of intracranial pressure, that's right, because reduce CO2 will cause vasoconstriction, will reduce the cerebral blood flow and reduce the intracranial pressure. Okay, simply C is right. Okay, do you want me to repeat it again? I think it is clarified now. Okay, Dr. Al-Khan, if you want to come back.
Yes, sir.
Okay, then this question, this one.
Still loading, sir. A 55-year-old woman sustained a hip dislocation following a road traffic collision. She presents with reduced sensation on the dorsum of the foot and weakness of the foot dorsiflexion. Which nerve injury is responsible for this presentation? The femoral nerve, option B, the sciatic nerve, option C, the superficial peroneal nerve, option D, the sural nerve, option E, the tibial nerve. Here mentioned the reduced sensation on the dorsum of the foot and weakness of the foot dorsiflexion. B, sciatic nerve.
Okay, so you choose sciatic nerve. Why didn't you choose the superficial peroneal nerve?
The superficial peroneal nerve also supplies the dorsum of the foot, but except the first wave space, which is
Okay,
supplied by the common
both of them are right.
nerve.
But one
Yes, sir.
sentence in the diagram before, in the diagram above, make me choose sciatic nerve, not superficial peroneal nerve. It is a hip dislocation. Hip dislocation above causing injury to the sciatic nerve, not superficial peroneal nerve. Superficial peroneal nerve starts after bifurcation of the common peroneal nerve at the level of the fibular neck, at the level
Yes,
of
sir.
the neck of the fibula, it is below. So when the patient has hip dislocation, reduced sensation over the whole dorsum of the foot and weakness
Yes,
of the foot dorsiflexion, so it is the common peroneal part of the sciatic nerve. It is the sciatic nerve at
yes,
all. not superficial peroneal nerve. A very tricky question, and both of them are right.
Yes, sir.
Okay.
Yes, sir. I'm looking for the common peroneal nerve, but
Yes. Okay.
check it.
This one.
A 37-year-old right-hand dominant man sustained a traumatic amputation of his right index finger while using a circular saw. The finger is retrieved and he presents to his local district general hospital. He is transferred urgently to the regional plastic surgery unit for replantation. How should a traumatically amputated digit be transferred for replantation? Option A, chilled dextrose. Option B, chilled Hartmann solution. Option C, in saline. Option D, wrapped in a sling film and placed in a crushed ice. Option E, wrapped in a saline gauze soak and put in a plastic bag and cooled in ice water. So it's option E, wrapped in a saline soaked gauze, put in a plastic bag and cooled in ice water.
Yes, excellent. I told before, any amputated
Yes, sir.
finger will be wrapped in saline soaked gauze, then cooled in ice water. Okay, that's right. Another one. This question.
You attend a trauma call to a 40-year-old patient in resuscitation room who has been involved in a road traffic accident and has sustained a significant isolated closed head injury and his glaucoma score is 7. Which one of the most appropriate way to definitely manage the patient's airway? Cricothyroidotomy, nasopharyngeal tube, oropharyngeal tube, orotracheal intubation, tracheostomy. We should maintain the definitive airway by endotracheal tube intubation.
Yes.
Oropharyngeal airway.
Okay, I said before, once 8 intubate. Okay, this intubation will be orotracheal intubation. Okay.
Yes.
I will
Orotracheal.
put orotracheal. Once 8 intubate. Okay. These are the indications of mechanical ventilation. I am going to clarify this for all. If the patient has insufficient oxygenation or ventilation, the patient has inadequate oxygenation or ventilation, this is an absolute indication for mechanical ventilation. Okay, this ventilation also needed when Glasgow is less than 8, once 8 intubate. Also, if the patient has severe facial injury and cannot protect his airway, we will go also for mechanical ventilation. Also, in patient with inhalational burn and respiratory distress, I will go for endotracheal intubation. Okay, this is also another question. These are the indication of intubation, not amputation. This is little wrong. Okay, presence of apnea, inability to maintain airway. If the patient has not the ability to maintain a patent airway, if the patient has to protect the lower airway or to protect the upper airway. Here is the lower airway from any foreign body, or patient with severe facial trauma. Okay, patient with an inhalational injury or inhalational burn, major facial burn or facial trauma, once 8 intubate, patient with status epilepticus not responding to any treatment, any patient with inability to maintain oxygenation and ventilation. This is an important photo. Apnea, inability to maintain patent airway, lower airway obstruction or upper airway obstruction, any inhalational injury or burn, major facial burn or facial trauma, once 8 intubate, status epilepticus not responding to any medical treatment, inability to maintain oxygenation and ventilation. These are all the indication of intubation. 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay. Another question. This one.
The decision to undertake limb amputation will be life-changing for any patient. It should only be performed in particular circumstances. In which one of the following situation is amputation of the lower limb considered absolutely necessary? A. Absent plantar sensation. Option B. Muscle tone in 2 or more compartments. Muscle loss in 2 or more compartments. Option C. Segmental bone loss greater than 1/3 tibial length. Option D. Uncontrollable hemorrhage from open tibial injury. Option E. Warm ischemia, time exceeding 4 to 6 hours. Option plantar sensation, no, it's not. Muscle loss, no. Segmental bone loss greater than 1/3 tibial length. Uncontrollable hemorrhage from open. In case of crash injury, uncontrollable hemorrhage from open tibial injury, we do amputation. I think.
Yes, this is an absolute indication of amputation, uncontrollable hemorrhage from a compound fracture. This is an absolute indication. Okay, absent sensation only, not an indication of amputation. Muscle loss
Yes, sir.
in 2 or more compartments can be treated according to fasciotomy or amputation, and this is a relative indication, not an absolute indication. Segmental loss more than 2/3, not 1/3, and ischemia time more than 6 hours. 6 hours are more important for limb. Okay,
Yes, sir.
so our answer here will be D, right? Last one. Okay, this question. Go on, Dr. Khan.
26-year, yes, sir. A 26-year-old motorcyclist is involved in a high-speed collision. He reports pain over the left chest wall and is short of breath. And his pulse is 120 per minute. Blood pressure is 98/66 milliliter mercury. Respiratory rate 22 beat per minute. His regular venous pressure is elevated and heart sounds are muffled. Trachea is centrally normal. Breath sound. Chest X-ray reveals multiple left-sided rib fracture. Cardiac silhouette is enlarged. Which one of the following is the most likely diagnosis of this patient? Tension pneumothorax. Option B. Ruptured thoracic aorta. Option C. Cardiac tamponade. Option D. Flail chest. Option E. Pericarditis. Here the most conclusive is cardiac tamponade due to muffled heart sound, elevated venous pressure, and option C. Cardiac tamponade. Sir, hello. Hello, can you
Okay.
hear me?
Yes, the patient here has hypotension and increased jugular venous pressure and muffled heart sound. This triad is fixed triad. Also, the cardiac silhouette is enlarged. This is called globular heart. This is right with cardiac tamponade. Okay, right? Another one.
You are
Okay.
treating 30-year-old man with a fracture dislocation of the ankle. The capillary refill in the foot is 2 seconds and pulse is weak but palpable. You need to reduce the dislocation using sedation in resuscitation room. Which one of the following option is appropriate regarding sedation for this procedure? A. Diazepam is preferred to midazolam when given intravenously. Option B. Sedation can ideally be given when patient has eaten 1 hour before. No, not. Sedation is optimal when the patient loses response to verbal commands for physical stimulus. No, the airway should be monitored closely by person performing the sedation.
I will share
cannot see
the
the
another.
option E.
Yes, these are the another options.
Option E. Ketamine is useful sedative drug as patient retain protective airway reflexes and spontaneous respiration and cardiopulmonary stability. Ketamine is a part of general anesthetic, I think. That's why it is not a part of sedation.
Okay, here I need just sedation. Okay,
Yes.
sedation only.
The
So
airway should be
ketamine
monitored.
characterized by dissociative anesthesia or dissociative sedation can give the patient sedation, not anesthesia, and associated with amnesia. The patient cannot remember what happened in the operation. Okay, so it's better to be used here is ketamine. Okay. Diazepam not used because diazepam is long acting. Okay. So the preferred here is midazolam. Midazolam is short acting barbiturate. Short acting barbiturate. So if I can use any barbiturate, I will use midazolam, not diazepam. Midazolam is short acting barbiturate, while diazepam is long acting barbiturate. Okay. Sedation is like anesthesia. So the patient should be fasting before the operation. Okay, so be fasting.
Yes, sir.
And sedation is like anesthesia. So the patient lost response to verbal or physical stimulus. Okay. Also, the patient airway should be monitored closely. Should be monitored closely by the patient performing the reduction, but not needed also because the patient is also sedated. Here, the correct answer is ketamine is used for sedative agent. Okay,
Okay, sir.
I will share some collected questions. Who also wants to participate? This one. Okay, who is ready? Please raise your hand. Dr. Ghada.
Okay. Trauma and orthopedics. First one, a 48-year-old secretary presents to her GP with a 3-month history of intermittent sharp pain in her forefoot at work, associated with the occasional numbness and burning of the third and fourth toes. The pain is relieved by removing her shoes and massaging the affected region. Examination reveals a decreased sensation between third and fourth toes. So, Morton's neuroma, option G, because
Yes,
of third and
excellent.
fourth
It is called
toes.
Mulder sign. Mulder sign is just decreased sensation or hypothesia between the third and fourth toe. This is a characteristic sign of motor neuroma. So one is G. Excellent. Two.
Okay. 35-year-old cleaner presents to her GP with 2-month history of a progressively worsening dull ache and stiffness in her left big toe. The pain is exacerbated by movement at the interphalangeal joint and relieved by simple analgesia. Examination reveals tenderness at the affected interphalangeal joint and warmth over the surrounding skin. This is bunion. A.
Okay,
Big
but what
toe.
about tenderness and warmth? This is an inflammation. So I'm
Yes.
going with bursitis.
Bursitis? That's like, okay, B, bursitis.
Yes. Okay.
Because
More
I thought
common to
about the
occur
big
also.
toe with pain, yes, stiffness and pain, yes.
Okay. Here two is bursitis due to attacks of
Bursitis.
inflammation, tenderness and warmth. Bunion is painless.
Okay. Yes, exactly. Third one, a 41-year-old mountaineer presents to his GP with an 18-month history of progressive lancinating pain in his left foot, radiating directly from the ankle to the bottom of the foot arch. His symptoms are worsened by prolonged walking and standing. Examination reveals normal foot pulses, but the patient's symptoms are reproduced with passive pronation of the foot. Passive pronation.
This is an important question. Also, it is called tarsal tunnel syndrome. Yes,
I'm
excellent,
looking.
Dr.
Yes,
Khan.
I'm just looking for the option. Yes, it's I, tarsal tunnel syndrome. There's pressure on the tibial nerve, right?
Yes, right, excellent. Okay, this is tarsal tunnel syndrome, or it's the flexor retinaculum of the foot, tarsal tunnel syndrome.
Yes.
Okay, structures passing through it is the
Tibial
tibialis.
nerve.
Okay,
And tibialis
muscles.
posterior.
Yes, tibialis.
Tibial nerve and tibialis posterior.
And posterior tibial vessels. Posterior
Yes.
tibial vessels. Okay, tibialis posterior and the flexor hallucis and the flexor digitorum. Flexor hallucis brevis and the flexor digitorum. Okay, another one. Okay.
It's the same
Also
idea as
important.
median nerve in carpal tunnel syndrome, right? The same idea
Yes.
when there's compression.
Trauma.
Okay. A 32-year-old male is involved in a high-speed deceleration collision. On arrival to the emergency department, he exhibits evidence of tracheal deviation and surgical emphysema in the neck. The ATLS protocol is followed and chest drain is inserted to relieve a right-sided pneumothorax. The patient doesn't show improvement following this, but continues to leak from the chest drain. So this is indication for thoracotomy because there's a continuous leak.
Okay, when the patient has continuous air leak from the chest drain, I said it is a tracheobronchial tree injury. Okay, pneumothorax and continuous air leak from the chest drain is a tracheobronchial tree injury. Okay, I think you lost the signal, Dr. Ghada. Can you hear me? Okay, Dr. Al-Khan, you can continue.
Yes, sir. A 25-year-old prisoner present to the emergency department 36 hours after being punched in the face, neck, and chest by his fellow inmates. While awaiting further assessment, he complains of severe pain in the neck and chest, odonophagia, and dysphonia. Examination reveals tachycardia, tachypnea, and subcutaneous emphysema of the patient's neck and chest.
Okay, we have here the triad of chest pain,
Yes, sir.
emphysema,
And emphysema.
and vomiting is lost. Okay, we have here pain, subcutaneous emphysema, and dysphonia, odonophagia. What do you think of?
Esophageal rupture.
Yes, excellent. Perhaps syndrome, esophageal rupture.
Perhaps syndrome, yes, sir.
Perhaps syndrome. Okay, that's right. 3.
And 50-year-old male is brought to the emergency department after being involved in road traffic accident. His initial assessment reveals no evidence of external injury or blood loss. However, he subsequently complains of severe tearing pain in the back and hoarseness of the voice. A senior review is requested. On repeat examination, the patient is found to have pulse rate is 140 per minute and respiratory rate 27 per minute, and a 30 millimeter of mercury difference in blood pressure is noted in both arms. Relating to pain in the back, tearing pain, and pulse pressure difference in both hand and rest pressure is scenario of aortic dissection, option A.
Yes, excellent. Difference of blood pressure in both upper limbs with severe chest pain, tearing pain in nature radiating to the back is an indication or suggestive of aortic dissection. That's right. This is aortic dissection. Okay, excellent. Then today we have discussed intubation, relation between CO2 and intracranial pressure. We have discussed the advanced trauma life support algorithm, hyperkalemia and hypercalcemia, systemic inflammatory response syndrome, and some trauma like trauma to the chest with pneumothorax, trauma to the neck, fracture larynx, trauma to the abdomen, and indications of laparotomy. Please, you can attend another sessions. I have finished today. The next session will be next Wednesday. See you all. Thank you for participation. Thank you and goodbye.
Thank you, sir. Thank you, sir, so much for taking this question.
Thank you.